Now invite Dr. Ritika Sachdev. She's an excellent surgeon, but I think more excellent administrator and lots to learn from you. Looking forward to your talk.
Thank you. I'll just be talking about the IPD because it is a large portion of our revenue, and the OPD effectively converges to the IPD. And like Sir said, every business works on a customer acquisition cost. And for us, eventually, the patient acquisition cost is the sum total of the sourcing, that is the marketing, plus the OPD cost that has gone into the patient. So I won't be talking about the OPD. I'll basically be sharing the IPD metrics. This is actually something that my team has prepared, so it's really what they do track. So first, I think we should all tell ourselves that it is very important to watch and have numbers, because what you don't watch, you don't monitor, you cannot address, and you can't make better. So you must, in the context of knowing the present, know the past. What was your last month, last year? And also try and predict your business. It is a very exciting thing that you should try and set a benchmark or a forecast and then look back at those numbers. So I'll just come to the IPD, sales, as well as the operations metrics that we target. For the sales team, it is their duty to get in more IPD patients. So we tell them to map channel wise or service wise. That basically means they should know where more IPD is coming from. For example, they may be focusing on one demography which is not giving useful patients. Maybe they don't trust the brand. Maybe they're not okay with the price. So wherever the patient who is converting is your TG, which is your target group, because not everybody associates with your brand. Then you have the percentage of patients that the sales team is getting. How many of them are being advised a particular service? For example, if you have a purely cataract center and the sales team is getting you patients who are less than 50 years, it is not your target group. However, if you have a refractive center, you have to focus on the 18 to 35 group also. So have the addressable audience being mapped and being validated that the sales team is making efforts in the right direction. Now we come to the operational profiling. You must capture data through multiple sources, HIS being the most authentic. A lot of doctors don't use the HIS, so get a lot of information from billing, especially for IPD, because billing is usually sacrosanct. We also have an OT register, a feedback mechanism, and we have review meetings. So this is the operational indicators that we map. First is that whenever a patient walks into the OPD, we tag the patient. A surgical patient has to be tagged because that is your maximum revenue patient. Once the patient is advised a surgery, only then he goes to the counselor and a tracker into the form of a counselor tracker is made. Counseling is same as compliance. That means if somebody has been advised a cataract surgery, is he choosing to get it done at your center? The counselor post the doctor makes a list of the patients advised and done. You should also have a cash credit mix. Sometimes credit patients convert easily in larger centers because they are not worried about the price they have to pay. So map your conversion for cash and credit separately. We also have a follow-up call done for patients either who don't convert or who decide to get the surgery done at a later time. Now, once a patient does decide to get surgery, this patient should be your brand ambassador, right? So then we do an NPS scoring. I'll talk more about it. We also break down each surgery which is done in terms of the service and the price that the patient is willing to pay. And then, of course, comes the clinical outcome measurement, which comes in terms of the UCVA, BCVA achieved, and the spherical equivalent and cylindrical power that the patient is left with. So coming to prioritizing the surgical patient, can be done in a software. I'm showing you the printout version of it. Each patient is given a sticker. We have a green sticker for cataract and a pink sticker for refractive, because these are the two most impatient patients. They can shop around. A retina patient is less likely to shop around because they come for specialty and a larger footprint hospital, retina and glaucoma specifically. So cataract and refractive definitely should be prioritized. The whole system should be wired to know this is a cataract patient or a refractive patient. In a large OPD, sometimes that does not happen, but ideally you should have multiple touch points. This sticker can be put by anybody, right from the front office to the optometrist, whoever realizes first that this is a surgical patient. Now, like I said, once you do the counseling, the counseling conversion, a benchmark is set. It is tracked doctor-wise and counselor-wise. So if a particular doctor or a particular counselor is having a better or a worse performance, you will be able to have a trend. We do expect a benchmark of greater than 60% in a center which is moderately aged. In greater age centers, larger centers, the conversion is much higher, can be up to 90% also, right? Now, once a counselor has, you may have lost patients, right? It's very important to know that you have done the patient, but what happens when you lose the patient? So you ask the counselor to note down the reason for not choosing us. You can also have a follow-up call, and sometimes there is a mix of junior or senior doctors. Offer the patient a repeat, even a teleconsult, or another opinion with a senior doctor of your center, right? And always centralize a random sample, in the sense that don't depend on the center to make all the follow-up calls. Centralize some of them so that you are able to have an independent audit of the performance of the counselor or the doctor. So just do a random sampling. And second eye will always remain as a follow-up till it is done. We also, for the counselor and doctor being able to follow protocols properly, also look at the same day rescheduling of the surgery. Because if the patient is being rescheduled multiple times because of TPA processing or blood sugar, these are operational issues that you will have to address, because they allow your planning to really not be proper. Because if you have allocated time in the OT and the patient is being rescheduled repeatedly, you have to have some addressable measures. So I'll just now move back to what happens when the surgery is done or not done. When the surgery is done, we should get a feedback from a large sample of our surgical patients. What we calculate is the net promoter score. A net promoter score is a metric that is used across industries, which basically means how likely is your patient to promote you, right? Talk about you and send other patients to you. It stems from one single question: how likely are you to send your friends and relatives to us? This is calculated on an 11-point scale, going from 0 up to 10. Okay, so if somebody says 9 or 10, they are your promoters. If they say 0 to 6, they are your detractors. That means they will actually talk ill about you. 7, 8, 9 are your passives. They will get 6, 7, 8 are your passives. So they will not talk about you. So your net promoter score is promoters minus detractors, because a negative voice is going to do a harmful impact. So ideally, a net promoter score above 50 is considered good, but our benchmark, which is the ideal benchmark in a service industry, is 72. So that is something we aspire for, and we rank all our centers as per the NPS to set up a competition grid for all of them. Now comes the pricing. It is very important that you see if your pricing is causing a problem in conversion. So you should ask the patient, why are you not getting done? We sometimes allow a 10% discount at the center level, because there may be intense competition, and we normally price ourselves 10% higher than the market as a pricing position. So in order to become competitive with the market, there may be some leeway of discount, but you will have to calculate this over a period of time. I've already spoken about this. This is the doctor-wise mapping. It is important not only to calculate the conversion of a doctor, but also the ATV, or the average ticket value of a doctor. For example, a doctor may be converting to a lower package very easily. If a doctor is trying to move up, trying to sell more of the femto or a trifocal, his conversion may initially go down, but his revenue is going to go up. And you can play on volume, but you can also play on value. So value is a good proposition, and so is volume, but you should track both. So this is the ATV of a doctor. And so our ATV varies very widely across the group. It can be 70,000 for a cataract and 17,000. depending on the place that we are doing the surgery. We also look at the IOL. You should know the IOLs that are being consumed, because you may have some bundling with the company, or you may have better gross margins with certain IOLs. So after this, I basically would want to come to a point. It is I think some sort of learning from mistakes. We always look at the center's revenue and the center's total surgery, but we must look at the product mix. This learning came to me from, we hire some people who are not from the hospital industry. So one of the persons we hired, he said that we don't even launch 3 phones similarly. So every product is marketed separately across groups. For example, in Samsung, you have a fridge market separately, a phone market separately, and a television market separately, and each of the verticals has to reach the target. So we have a product mix, in the sense, if cataract conversion is good but refractive is low, you have a different investment for refractive. So track each product, each conversion separately. The cataract separately, the refractive separately, the retina separately, the glaucoma separately. And always have a trend line for each. Right? And volume value is what I had said. Know your gross margins, because only if you know your gross margins do you know what is the volume you need to get and what is the discounting you can do. For new products and services, this is something that we did when we launched a new product, for example, Smile and Femto. Train the people about the new product, set targets, but gamify the whole thing for them. Because a lot of what we say is abstract, just like a lecture is, but if you gamify it and give them like a scorecard or a campaign. For example, we had a Femto 100 campaign when we wanted to hit 100 Femto numbers. Now we may be doing much higher, but it just creates a scorecard for the entire team that you can look at every day. And gamification is like, that's how children get addicted to video games. Getting a scorecard is like a dopamine kick, right? Every time you see the scorecard going up or meeting a target. So that is the gamification you can do for new product lines and services. The final thing that we must monitor as doctors is, of course, the adverse event or the complication rate. Like I said, not all doctors document their adverse event. So we take billing as an indicator. Any procedure that has to be redone in the OT is done free of cost, but a billing of 0 is done. That is a redo billing. So anybody who requires another intervention will be mapped. So this is the adverse event. And then, of course, we have anesthesia adverse events. We have visual acuity better than 612, or we divide patients into those with a guarded visual prognosis and not guarded visual prognosis. And this is can be in tune with your NABH indicators. Post-op spherical refraction, which is an indicator of your biometry, is an optometry kind of an audit. So I just like to end with the top tips. Prioritize your surgical patients. Always have different criteria for different service verticals, be it cataract, be it refractive, and the others. Do have outcomes and benchmarks, but what is most important is to automate your data points and to plot them over time to discover the trends. Goal setting really is the first step for turning the invisible into the visible. But always remember, do not cut paste somebody's strategy to your own. For example, volume or value, you have to find out what mix works for you. Refractive or cataract, city specific pricing. So you cannot cut paste or copy anybody's strategy. Think long term, never undercut your brand or your vision. Identify the gaps of reasons of non-conversion or unhappy patients and address them, be it in IT, HR, or equipment. Thank you for your attention.
A question to wonderful talk, superb talk. She's one of your age group. So if she can do it, I'm sure all of you can do it or already are doing it. So just this question to Dr. Debashish or Dr. Mahipal, both of you. Now, when a young person is going to start a practice in a particular place, does he price his charges based on the surrounding practice, or does he start it lower? But then if you start it lower, it gets difficult to raise the pricing. So what would you advise this young audience?
You got that very wrong. You can raise your charges, but you can't bring down your charges.
No. I'm just asked a question. I did not say about my thing. These young people who are starting their practice.
we are minimalistic and frugalistic persons, Mahipal will have a different answer. I think for a youngster, it's better that, pricing is not a shadow pricing. We don't believe in shadow pricing. Chitra charges this, so I must charge. Otherwise, I'm less competent than Chitra. Is something, a logic we don't buy. You have to get the numbers right. You have to get your, like Ritika gave a lot of matrices.
Yes.
You get the matrix right. And then you decide on a pricing. But if you say, should I underprice or be more towards the fair side of pricing, or are we going for a number thing, or are we going for a revenue thing or a bottom line thing? If you are planning a number thing to take care of your future, I think that is a better way, because as I said, that growth is so essential in an organization. So if you a little underpriced, yeah, and in Disha we found that if you surprise your patients with good quality and a very fair price or a low price, the acceptance is wonderful. It could happen other ways, but it's a better way to get numbers for beginners, I would say.
Yeah, thank you so much, sir. Excellent
Just
talk,
wanted
Dr.
to add a
Ritika.
point
Yeah,
that we
yes.
do
Yeah.
pricing. You're not the leader when you're entering a market.
Yes.
So you actually have to look at the leader.
Yes.
So like in Kolkata, our prices are lower than in Delhi, much lower, because we cannot dictate Kolkata.
That's exactly what I wanted.
Always look at the
No,
leader.
see,
You gave a
pricing-
moral lecture. She's telling
No,
practical points.
No, I'm telling. No, I am always willing to, share things. It is what is, now let us come to pricing. What is a comfortable spend for a cataract surgery? I think everybody will agree 1 month's GDP or 1 month's per capita. So if it is 80,000 in South Delhi, it is 20,000 in our districts and 30,000 in the town. So that is our pricing. So, I mean, please have that pricing structure in mind.
Yeah,
I
Dr.
think
Ritika.
Dr. RDR can also give some thoughts on that. No, pricing is very, very critical.
Yes, very
I
critical.
agree.
Absolutely critical.
Yes.
Not out of the-
But you have a lot of IOLs to price your cataract in a range. The other important factor is that if you're starting your practice and looking for insurance, your cash prices also determine the insurance rates that you get. So practically, please keep that into account.
Yes. Thank you very much.
Regarding
I'm
the
lucky I
targets-
heard a bit of your talk.
Just one question, Dr. Ritika. Regarding the targets that you mentioned, every year, how much, by what percentage do you increase the targets? And what are the factors, quickly, if you can?
If we increase by some, he increases by more.
Okay, we'll go on to our next session. Thank you very much.
Ritika, one question.
Yes, sir.
You measured a lot of things.
Yes, sir.
How do we reward these things?
Sir, in terms of
I spoke to you about rewarding, no, doctor? I spoke in the first talk how you have to reward.
No. I want the measurables.
Measurables.
the
Okay.
measurables in terms of the
Like if you do 20% more, what do you get?
Yes, exactly.
Sir, so we have an incentive plan. If per center, mostly we treat them as a group. So if they reach together, they get more. If we feel that sometimes we have campaigns, for example, in the peak months, we may do individual incentives per counselors, and the doctors also have some incentive plans. So they are given the scorecard. Eventually, what happens is doctors may not be only motivated by the incentive. We give them a relative conversion of other doctors of the same center because they are getting the same patient mix. So we don't, and in ATV, every doctor knows their ATV, and the incentive is different for the premium procedures. So therefore, there is an incentive to upgrade, there is an incentive to do more also, and there is an incentive as a team also. So that is.